Hello everyone and welcome to our module on eye movements. Let's start by reviewing the muscles of the eye and their effect on eye movement. In order to do this, I've drawn an eye in the middle of the screen. There's a nose on the right side of the screen representing the medial side of this eye on the screen, the midline of the face, and over here is the lateral side of this eye over towards the temples. The two easiest muscles to understand in terms of eye movement are the lateral rectus and the medial rectus. The lateral rectus moves the eye laterally and the medial rectus moves it medially. The major effect of the superior rectus is to tilt the eye upwards or to raise the eye, and the major effect of the inferior rectus is to depress the eye or turn it downwards. There are two oblique muscles of the eye, the superior oblique and the inferior oblique. They both have complicated effects on eye movement in multiple planes, but the thing you want to remember about these muscles so that you can understand the nerve palsies we'll talk about later is as follows. The major effect of the superior oblique is to turn the eye downward and to intort it, which means to rotate the eyeball this way. The major effect of the inferior oblique is to raise the eyeball and to extort it, which means to turn it that way. If you remember it like this, it's very simple to understand the nerve palsies we'll talk about in a few slides. I've cleared away my ink so we can talk about the innervation of the muscles of eye movement. All of the muscles shown in blue are innervated by cranial nerve 3. It innervates the majority of the muscles of eye movement. Cranial nerve 4, the trochlear nerve, innervates a single eye muscle, that's the superior oblique. And cranial nerve 6, the abducens nerve, innervates a single eye muscle, that's the lateral rectus. And many medical students use this chemical formula to memorize the innervation of the muscles of eye movements. The chemical formula is LR6SO4. That stands for lateral rectus innervated by cranial nerve 6 and superior oblique innervated by cranial nerve 4. All other muscles of eye movement are innervated by cranial nerve 3. And then finally, I just want to mention that besides eye movement, cranial nerve 3 innervates some muscles that carry out other actions related to the eye. Cranial nerve 3 innervates muscles that can raise the eyelid. It also carries parasympathetic fibers with it that can constrict the pupil. For the USMLE Step 1 exam, it's very unlikely they will ask you what individual muscles of the eye do. Instead, they will want you to be able to diagnose nerve palsies. So for example, if a patient has a third nerve palsy or a fourth or sixth nerve palsy, they will want you to know how to recognize this based on examination of eye movements. And all of these nerve palsies can occur in various CNS syndromes, including strokes and tumors and aneurysms. Before we get into the individual nerve palsies, let me do two things. First, let me review some terminology. When we move the eye away from the nose, we call that lateral motion of the eye. We also call it abduction or abduction of the eye. When we move the eye toward the nose, we call that medial movement of the eye. It's also called adduction or adduction. And then the second concept that's important to understanding nerve palsies of the eye is the symptom of diplopia. Diplopia means seeing two different images of the same object. This is a picture of what it can look like on the screen. And diplopia occurs in many of the eye palsies that we'll discuss. And you should know that the diplopia that occurs in nerve palsies of the eye is always binocular. What this means is that the diplopia is only present when both eyes are open. It resolves when one eye is covered. So when a patient presents to clinic with diplopia, one of the first things you do is ask them to cover one eye and see if the diplopia goes away. If the diplopia persists when the patient covers an eye, that is monocular diplopia. That's usually a lens problem like astigmatism. In all of the nerve palsies we'll discuss in this module, the diplopia goes away when the patient covers one eye. That's because it requires both eyes for the diplopia to occur. Therefore, it is said to be binocular. The first nerve palsy we'll discuss is an oculomotor or third nerve palsy. And in order to understand this, let's review what the oculomotor nerve does. First of all, it moves the eye up and medially. It moves it up via the superior rectus muscle and medially via the medial rectus muscle. It also elevates the eyelid via the levator palpebrae muscle. And finally, it's responsible for pupillary constriction via the sphincter pupillae. This is not a direct result of the oculomotor nerve. However, parasympathetic fibers from the Edinger-Westphal nucleus travel with the oculomotor nerve, and therefore when there is damage to the oculomotor nerve, there can also be damage to these parasympathetic fibers, and that can be a problem for pupillary constriction. So if you understand that, it's very easy to understand what an oculomotor nerve palsy looks like. On the affected side of the body, the eye will be down and out, as shown in this picture. There will be ptosis, which is eyelid droop, and the pupil may be dilated. When a patient presents with a third nerve palsy, it's very important to determine whether or not the pupil is dilated. This is called the rule of the pupil. So patients with a cranial nerve 3 lesion will have an eye that is down and out, as shown in this picture on the screen. If the pupil is dilated, this means the parasympathetic nerves that travel with cranial nerve 3 are impacted. These fibers run on the outside of cranial nerve 3, and therefore they are easily compressed by a mass, especially a posterior communicating aneurysm. For this reason, if the pupil is dilated, you must consider that the patient may have an aneurysm, and that patient often needs imaging of the brain. If there is an absence of pupillary dilation, this suggests ischemia is the cause. Cranial nerve 3 ischemic damage is very common, especially among diabetics. They will present with a third nerve palsy, but they will spare the superficial fibers to the pupil, and therefore the pupil will not be dilated. Thus, the rule of the pupil is very important when evaluating cranial nerve 3 lesions. Now let's talk about what happens when there is a palsy or damage to the trochlear nerve, cranial nerve 4. As I told you earlier, this cranial nerve innervates a single muscle of eye movement, the superior oblique. And also, as I told you before, although this muscle has complicated effects on the eye, the major effects are to turn the eye down and intort the eye, which means turns it towards the middle, towards the nose. This is very important for doing things like reading and walking downstairs when you have to look downward and towards the midline. What this means is that patients who develop palsy of cranial nerve 4 will have diplopia, and their eye will be tilted outward. If you look at these two eyeballs at the top of the screen, imagine we have a dysfunction in cranial nerve 4 innervating the eyeball on the left. It will therefore not be able to depress, and it will also not be able to intort like this, and therefore it will be pointing up and outward. The other eye is not affected, so it is normal. When this happens, patients develop diplopia, but in particular, it's very hard to look down and in for things, like I said before, descending the stairs or reading a book. To compensate, many patients will tilt their head away from the affected side. So to understand this, let's look at these two eyeballs here. If this patient tilts their head away from the affected side, which is over here, that will straighten out this eye. This eye over here has normal control, so it can modify itself to be straight, and therefore by tilting the head, the patient will normalize this eye here, which is affected by the palsy, and the diplopia will improve. Our final nerve palsy involves the abducens nerve or cranial nerve 6. This cranial nerve innervates a single eye muscle, the lateral rectus. When the lateral rectus does not function, the affected eye may be pulled medially at rest. In addition, problems are worse on horizontal gaze because on horizontal gaze you need your lateral rectus in order to move the eyeball laterally, and the affected eye can't move laterally if there is an abducens lesion. So if we look at the bottom of the screen, I've demonstrated what can happen with a right cranial nerve 6 lesion. The right eyeball may be normal or it may be pulled slightly medially depending on the severity of the lesion at rest. However, when the patient tries to gaze to their right, the left eyeball comes medially as it should, but the right eyeball is stuck and cannot move laterally, and thus the diplopia gets worse on horizontal or lateral gaze toward the side that is affected. As I mentioned before, if there is a severe cranial nerve 6 palsy, the affected side can have an eye that is pulled medially. This is a condition known as astropia. It's a type of strabismus. Strabismus is a misalignment of the eyes. In astropia, there is an inward turning of one or both eyes, and this can be seen in cranial nerve 6 palsy. At the bottom of the screen, I've shown you an example of astropia. This could occur with a severe cranial nerve 6 lesion on this side. The eye is pulled medially because the lateral rectus muscle is not working properly. One potential cause that you always want to think of when you see a description of a cranial nerve 6 palsy is pseudotumor cerebri. I discussed this condition in detail in the module on ventricles and sinuses. Pseudotumor cerebri occurs when there is high intracranial pressure. This can lead to a cranial nerve 6 palsy. The course of cranial nerve 6 is highly susceptible to pressure forces when the intracranial pressure becomes elevated. Sometimes high intracranial pressure can lead to a bilateral cranial nerve 6 palsy. There may also be papilledema on fundoscopy, especially in a board question. And the classic demographic that develops pseudotumor cerebri is an overweight woman of childbearing age who presents with headaches and a cranial nerve 6 palsy. The diagnosis you want to think of in that situation is pseudotumor cerebri. And that concludes our module on eye movement.